and thanking everyone for being a part of our webinar today. So my name is Tim Craig. I'm the Director of Education for Lincoln Healthcare. Welcome to our webinar on the new mandated bundles and how post-acute can capitalize. We've got quite a few things to review today, so we'll get started very quickly. This webinar, as you know, is complimentary, and it is an opportunity for us to bring pressing information and timely information that we wouldn't otherwise have the opportunity until our conferences to do so. And so we thank you for tuning in this afternoon. Look for more of these in the future as more things arise that are pertinent to our audience and our communities. I'm here today with David Ellis, the president of our company, and over the course of the next 45 to 50 minutes, we are going to walk through the implications for the mandated bundle payments in AMI and CABG for the post-acute sectors. I want to remind everyone that there's an opportunity to submit questions, and we would encourage you to do so. There's a white question box on the side panel that is part of the interface, and you can kindly put in your questions. And when you do so, we would ask that you start with your subject matter so that we know the relevance of your question and can sort them appropriately. We're going to be recording today's session so that we can send it out and make it available to those who are not able to join. We'll send you an email with a webinar link that will have access to the audio and to the PowerPoint presentation. Before we get started with a brief opening presentation, I'd like to take a moment to thank our panelists and introduce them to you. So Brian Fuller is our President of Value-Based Care for Navi Health. Navi Health is a post-acute care management services and technology solutions company, and it's a division of Cardinal Health. Navi is the second largest bundled payment awardee convener for hospitals in the nation. So welcome, Brian. Dave is the CEO and founder of Archway Health, whose mission is to fix healthcare reform by designing and implementing market-leading bundled payment initiatives. Archway is an awardee convener. Julie Uhrig is the Director of Healthcare Strategic Initiatives for Life-Enriching Communities and operator of continuing care retirement communities in the greater Cincinnati market. Julie is also the Director of Clinical Operations for Post-Acute Care Network, a Model 3 awardee in partnership with Episcopal Retirement Services and Life-Enriching Communities. And finally, Jean Wang is Vice President of Business Development for Remedy Partner. You've surely heard of Remedy. They're the largest awardee convener in the nation, and they represent approximately 60% of Model 2 and Model 3 participants. So we have a very distinguished panel. Welcome. Thank you for joining us. And at this point, I would like to ask Jean to take over. And Jean is going to walk us through some of the basics to get everyone on the same page and do some level setting before we jump into our conversation. So Jean, I'll give the floor to you.
Hey, thanks, Tim. Hope everyone can hear me. I've just got 3 slides to cover today, and I thought the best way to give people a sense of what the new mandated bundles are would be to compare and contrast them to CJR, which has been out for a while, and many people have at least a basic understanding of. So there are many things that are the same, but there are many things that are a little bit different. I would also stress that we're currently the regulations are currently have been proposed, and there's an open comment period that ends, I believe, October 3rd. So I would tell you that CMS values the participation of post-acute providers. By number, there are more post-acute providers participating as episode initiators in the program than there are any other type of providers. Post-acute providers do have a voice. So just to give you, so I've got 3 pages here. I'll just walk through some of the differences here. Obviously, cardiac bundles are new. I did not include, there's also a new orthopedic bundle. It's called SHFT, or Surgical Hip Femur Fracture Treatment, which is an add-on to CJR. But I'll just focus on the cardiac bundles. And as it's noted here, they're proposed regulations. The 2 cardiac bundles are AMI and CABG, and you can see the DRGs that are included here. the effective date's obviously almost a year later than CJR, and the risk period date starts a year later as well. And the end date is also a year later, December 31st, 2021. The locations are different. There are 67 locations that have been announced for CJR. The MSAs have not been announced for the new cardiac bundles. The femur procedure that's added to CJR is in the same 67 MSAs, but the 98 MSAs for the cardiac bundles have not been announced yet. Also, like CJR, the only mandated participants are acute care hospitals. And part of what that means is that no other provider can participate as a participant. There are other roles that providers can play in sharing risk, but not in taking a lead in managing the risk and getting the risk and reward for that. Also of note, there's currently no role for a convener in this in the new mandated bundle. So conveners that have historically been helping providers in the BPCI program are not allowed to participate. Okay. In the next slide here, similar to CJR, provider participants can participate by taking some risk, and the amount of risk that can be shared is similar with the CJR program. It's 50% of the total risk can be shared by the hospital participant, but no more than 25% maximum per provider that they're sharing risk with. On the next line here is a very significant difference for those SNFs that are participating in, or post-acute providers participating in the bundle payment program. In CJR, if the hospital is in a mandated CJR region and the SNF in that area has selected the major hip replacement bundle, the SNF has precedence and therefore has risk, and the hospital can shift its risk in that program by sending patients to that SNF that has in the BPCI program that has chosen that bundle. It is not the case, as proposed in for cardiac bundles, that the BPCI participant has precedence. They do not have precedence, so there is no. So if a bundle is, if a AMI or cabbage bundle is selected by a SNF in the BPCI program and it's in a mandated MSA, that patient will be, the hospital will have risk for that patient. There's also a difference in the proposed ACO precedence rules, and for traditional ACOs, the CJR and cardiac bundles both have precedence over the ACO. But for next generation ACOs, they have precedence over the BPCI participant. And actually, this is the second to last slide. The pricing methodology is the same, is expected to be the same for both CJR and cardiac. It moves from partial weighting for your historic pricing with regional pricing towards full regional pricing. So that in effect means it moves from some weighting of pay for improvement, where you're trying to do better than you have in your pricing period, to pretty much full pay for performance as you're compared to your peers in your region. The last point on this slide is we believe that there will be a difference in terms of the impact of the mandatory cardiac bundles and the CJR bundles. One of the major concerns for a lot of the SNFs that Remedy works with in the Model 3 program is that with CJR and other movement in value-based contracting, there's a movement to reduce SNF utilization, particularly for the lower acuity cases, And what that does is it shifts more challenging cases to SNFs, and so when SNFs when hospitals are looking at their options in CJR, they're shifting, they're reducing SNF utilization, and at the same time shifting more acute patients to SNFs. We believe that in the cardiac bundles, the big opportunity for hospitals isn't necessarily in reducing SNF utilization, it's really in reducing readmission rates. So it's my belief that the cardiac bundles will not impact SNFs as much as the CJR bundles have historically. But again, we'll have to see how that plays out. The last page here, having trouble turning the slides, I'm sorry. There we go. There is a phased implementation for risk sharing. So CMS typically reduces the downside penalties early in the phase-in period, and you can see that here for the first 6 quarters. There is an upside that's capped at 5%, but there's no downside for the first 4 quarters. First 5 quarters, I'm sorry, and then the next 3 quarters is capped at 5%. And you can see it symmetrically increases the capping on both downside and upside in 2019, and then it's capped at 20% upside and downside in 2020 and 2021. Tim, I think that's my last slide. I'll hand it back to you. Tim?
Sorry, Gene. Real quickly, as a follow-up question, the question here was, so using CJR as a guidance, approximately how far in advance were the 67 MSAs announced, and how might that influence the announcement of the 98 MSAs for this mandated cardiac bundle?
I'm sorry, I can't remember the timing on that. I don't. Panelists have input on that.
Yeah, Gene, this is Dave. So Tim, it's hard to say. They've approached them differently. In CJR, they actually announced the MSAs at the same time that they announced the program, and then after the comment period, they actually reduced the number of MSAs from 75 to 67. This time around, as you know, they have not announced the MSAs. So they took a different approach. I suspect, you know, the comment period closes early October. It took them about 6 weeks or so after the comment period to come out with the final rule. They came out with the final rule for JR in November of last year. I suspect we'll see the final EPM rule in November, early December, and I suspect at that time we'll see what the 98 MSAs are. That's an estimate. You know, I'm surmising all that, my assumption.
Let's just spell out what that means in terms of from the time the MSAs are announced until it goes live. We're talking approximately 8 months. Is that right?
Right, exactly.
Okay, great. Gene, for that intro, really good information. We're going to jump in now. I want to get Julie's take and start our conversation specifically around a Model 3 organization that has experience in AMI and CABG. So Gene referenced the fact that his belief is that one of the principal factors that will drive some of the involvement with post-acute providers is readmission reduction. Julie, help us understand, for someone who has been directly involved as a Model 3 for these episodes, what else can you tell us about the management of these DRGs, patient stability, readmissions, complexity of episode? What else can you lend that will give us an understanding of how different this is going to be from CJR?
Well, yeah, obviously, although CJR does have, you know, we are getting some of the more clinically complex patients. Generally, with AMI and CABG, those patients are at a much higher risk, just like Jean said, for readmission. So the things that we need to do in order to be able to manage those are things like, building the infrastructure to manage these type of patients, which may include things like staffing, upskilling your staffing. With the staffing shortages today and hard to find the good people, sometimes it's also partnering with hospitals or medical directors to provide education. Another thing that we're doing is working on, the diagnostic testing that we have available in our communities and our skilled nursing facilities, and the timing of those diagnostic tests. For example, things like, getting EKGs done in red, x-rays, those kind of things. Those also help us cut down, obviously, ideally on readmissions by identifying problems earlier. Clinical pathways, care pathways are also a big part. The care pathways are designed to really recognize changes as early as possible and be able to have those conversations with the physicians about what we're able to do in our skilled nursing facilities, so that the perception is that we really can't do as much as they think we can do, and we have to send that patient to the hospital. It's helping them understand what we can do, the labs, the tests, the IV medications, the things that we're able to do, make sure that they understand that. I think those are some of the big things that we're working on, and just individual physician protocols, sometimes with CABG patients, MI patients being more clinically complex. Certain cardiology groups have certain hospitals have different protocols we need to follow as far as reporting certain labs, reporting certain data and updates, and learning how to manage that.
Great. Thank you. Well, so before we get into some of those specifics, I'd like to just step back real quickly and ask Brian. Brian, I know that you've had direct involvement with health systems, and Jean alluded to the fact that, this is an example of where the risk-bearing entity is the health system. And we've just spelled out a timeline in which, from the time the MSAs are announced until this go live, there's less than 3/4 or less than 9 months. So from your estimation, help us understand what is the preparedness for the health systems, and in general terms, and how might that influence the way in which they will be looking for their post-acute partners for assistance?
Yeah, well, I think there's a real difference this time than when we were discussing CJR, and you heard some of the panelists already talk about that. Because the 98 MSAs were not announced in the proposed rule, there's really been very little reaction from hospitals and health systems at this point. We're not seeing kind of the active reaction to this rule the way that we saw with CJR, and I think, again, mostly that's because they don't know at this point whether or not they're in or they're out. And so I anticipate that we'll continue on the AMI and the CABG bundles to experience kind of a wait-and-see approach by hospitals until those MSAs are announced, likely to be in the final rule in November, as Dave alluded to. I agree with that. And then I think you're likely to see kind of a flurry of activity, particularly if we go into early next year, in terms of, very similar to what we saw with CJR. I think it will be, as again, one of the panels alluded to, less intense. So things like preferred provider networks, I think you'll see hospitals gathering data, again, on their post-acute care providers in these two big episodes. And they'll be looking for those that are managing readmissions the best, particularly AMI. CABG is a fairly low post-acute care utilizer overall. So I think if you just rank order them, AMI of the two is the real kind of opportunity here for post-acute to step up and play a role, both in terms of managing costs and also managing readmission. For the hip and femur fracture episodes, I think you will see, and probably are already seeing, some reaction from the industry to be able to incorporate those episodes into what they're doing for their joint replacement bundles today, because those 67 different MSA hospitals know that they're in. The other thing that's unique, if we're just comparing kind of the hip fracture and the cardiac bundles, is hip fractures obviously are high post-acute care utilizers, particularly of institutional post-acute care. So inpatient rehab facilities and units, this is one of their top diagnoses from a volume standpoint. They're also typically a very high SNF length of stay among hip fractures. So I do think you'll see a sooner reaction and a more intense reaction from hospitals, very similar to what we've seen in other bundles with hip fractures. I think the cardiac will be a wait and see until the final rule, and then less intense following.
Brian, David Ellis here. I want to throw out, just maybe it's overly simplistic, but I'm just trying to get my head around this. So, you know, our audience is largely, nearly entirely one of two groups. We have SNF providers and we have home health providers and suppliers for those two groups. So let's take each of these things, AMI and CABG, and try to help me understand, for the SNF audience, is this good news or bad news, and how bad? And for the home health audience, is this good news or bad news, and how, presumably it's somewhat good, better for home health, so how good is it? Let's start with a really, coarse, blunt analysis here. Is this good news or bad news for both audiences?
Yeah, I think again, just drawing upon the differences, I think for a hips and femur fracture, depending on the market you're in, and this is a conversation we had in prep for this call, and I know that's tough to have a conversation in a forum like this when things are so market dependent. But depending on the market you're in, this could be good news for SNFs. And the reason I say that is, again, in many markets across the country, IRF is the first post-acute care setting for a lot of hip fracture patients. And so for a SNF that can prove its ability to manage those patients just as effectively or more, you could see some shifting downward from inpatient rehab into skilled nursing. The other, dynamic that plays out in a lot of these markets is, even if IRF is the first PAC setting, patients often then, after the IRF, go to a SNF, a lot of times for weight-bearing issues. So again, I think it could be, if you're in a market where there's a lot of IRF volume from hip fractures, this could be potentially good news for you in terms of the ability to shift volume. I still think, the pressure to better manage readmissions and length of stay is going to continue. I don't know that it'll be as drastic as it was for joints, just because joints is a much simpler patient population. So, I generally think, I would say overall, it's neutral, could be slightly positive on the hip fracture side.
Okay.
On the cardiac side, it's a little harder to gauge, I think, as Julie pointed out, because of the complexity of these patients. It's really about managing readmission. We don't see some of the low-hanging fruit, if you will, on utilization as we do in some of the orthopedic and surgical cases. So I think, if you can really illustrate best practice performance on readmissions, again, particularly for AMI, most of the CABG expenses are really in the hospital. They're not in post-acute, and readmissions don't occur in post-acute. So it's really about the medical AMI. For those that can illustrate best practice readmission performance, I think you could also be a winner, if you will, under these bundles.
Okay, so if I had to summarize, Brian, for the SNF side, you're saying the CJR expansion of this is probably a positive, and the cardiac is sort of mixed, sort of uncertain whether it's a positive or negative overall for the SNF industry.
I think that's right. I'd be interested to see if my colleagues agree with me. But yes, that's the way based on the data I've seen and experience in bundles, that would be how I summarized it, correct.
Dave, Gene, any difference on that?
Yeah, David, this is Dave Terry. I guess I'm not as optimistic as Brian. I think that I do think it is complicated and dynamic and depends on the market you're in and kind of utilization patterns in your market. But I think that it will be net negative for SNFs. We just see.
Which one, Dave? Our expansion or the cardiac bundle? Both.
Well, I think Brian is very much on top of the data in the cardiac side. I mean, SNF utilization in cardiac is relatively low compared to joints historically, but I just think that we're going to see providers put much more scrutiny on all of these things as these programs start to expand, and that's going to, for better or for worse, in fee-for-service, and this is a pejorative statement, so forgive me, but fee-for-service, no one pays attention to any of this stuff. But when you get into a bundle, people start paying much more close attention, and that has an impact on where patients go post-discharge. I know NaviHealth and Remedy are both very focused on that, and so are we, and there's much more scrutiny around that and coaching our customers to be much more, to pay much more attention, and then also more scrutiny around length of stay. So I understand that not that many patients go, but when they go, they're going to go for shorter, and fewer of them will go.
So Dave, I get it. So you're more bearish for SNF. So does that mean by the flip side of that coin, you're more bullish for home health? As utilization goes down for SNF, does it go up for home health?
Maybe. I mean, I'm not as bullish as I was maybe a year and a half ago. Again, I think we're just seeing a lot more scrutiny on exactly what services are provided and the value-added nature of those services. And is it, a lot more scrutiny around the value of an episodic payment relative to physical therapy. Obviously, the cardiac program is a huge win for cardiac therapy because of the specific rules there. And I think we'll see those folks step up in a different way, which could put more pressure on home health. We're seeing BPCI put pressure on home health and create opportunities for outpatient PT that wouldn't have expected. I think good home health agencies who really embrace this can do well, but it's not, it's not just as simple to say home health is going to be a big winner, because there will be more scrutiny on what they do and the value of the services that they provide as well.
So again, not to repeat it, but the upside goes to who then? Cardiac therapy, outpatient, maybe some home health?
Yeah, no, I think it's net positive to home health, but I do think they'll have to be patient acuity will go up, scrutiny will go up, pressure for value will go up, and competition from outpatient therapy will go up. And outpatient therapy is definitely, I think, a big winner in all these programs.
Outpatient therapy. Okay, that's great. Gene, any significant difference from what Dave said?
Yeah, I'll work backwards from those comments. I agree with Dave completely. I think outpatient therapy will be a big winner here. I think the issue for home health is that they may get more cases, just as home health is probably getting more cases as a result of BPCI. I think the concern for home health is that they're getting more cases with much higher acuity, and home health is pretty much is paid on a case rate. So if you're paid the same amount but your patients are much sicker, you might get more volume, but you might not be happy with the volume you're getting because your service costs will be much higher. I think there will be more revenue for home health, but much more pressure on margins. Going to the comments on the expansions, the expansion to CJR with hip and femur, I think that's probably going to be. I feel that's probably going to be a negative because of the reduction in volume. I think I'm with Brian.
Gene, negative for SNFs?
Negative for SNFs because of the volume, because I think they're going to, people will cut volume. And that's the biggest problem for SNFs with hips and knees. But I think I think Brian, I agree with Brian on AMI and cabbage. I think that might be a positive. A lot of this is really also going to be, I think it's going to hit different types of players differently. I think those who are well-positioned, willing to share risk, high-quality players, and efficient, I think could actually gain. I think the pie is definitely going to get smaller. There will be SNFs that will not survive this process, but those who can, there are some that will gain market share. They will get a bigger piece of a smaller pie and net end up with more. not an easy thing to do. I think the pie is getting quite a bit smaller, and it's hard to get a lot more market share, but that's the win, is if you can get a bigger piece of a smaller pie.
Yeah, that's great.
So keeping with that same vein on this area of the narrowing of networks, we've all witnessed with CJR some extreme examples of narrowing of networks, we spoke about this in some of our preparation. I'd like to know the group's take on how they foresee the networks becoming narrowed and what that may look like going forward. Brian, I know that we spoke of some examples in CJR in which some of the networks went from 50 SNFs down to 5 SNFs. Do you anticipate that there'll be as sharp of a narrowing, and why or why not?
Yeah, I think it really depends on if we're looking at specific bundles or if we're just talking about overall. A comment that Dave made that I completely agree with is, if we just step back from this and look at it in aggregate, I do completely agree that the intensity of this activity changes behavior in markets. And so I think where we might see the network initiatives kind of intensifying is because this is another big signal that fee-for-service is going away and that value will be required from all involved in a 90-day period. So, for those markets where, those 98, for example, we could have overlap with the 67 CJR markets. And so for those markets, now the value imperative has just increased itself. Those would be markets where you would expect to see, really intensifying narrow network activity. If we're just looking at cardiac bundles specifically, in terms of the role that post-acute plays relative to the role that post-acute plays in CJR, I don't think it's as intense. It's not as a big percentage of the 90-day spend. Post-acute doesn't have as big of a role in the readmissions, again, particularly for cabbage. And so, just myopically on the cardiac bundles themselves, I don't think it will be as intense. I do think it will happen, but I think in the aggregate, narrowing of networks or preferred provider network formation is one of the hottest topics we see right now with our partners, both hospitals and health plans. And so I think this is another imperative for those that haven't started that work yet to perhaps begin that work or intensify the work that's been going on. In terms of the metrics, I don't think they're going to be any different than what they've been before. It's going to be all about, performance on quality, whether we like it or not, 5-star rating, pressure on readmission rates, close monitoring of SNF length of stay, kind of all the things that we've talked about in prior LTC 100. I think those will continue to be the metrics going forward.
And this is so go ahead, Tim. Go ahead.
No, please, Dave, go ahead.
I just want to pick up on what Brian said. I think that the whole thing is intensifying, right? So, BPCI came out, there were a handful of providers, in the grand scheme of things, that participated in that on a voluntary basis. CJR came out, and you could have written that off as just joints. But now with CMS coming out with another program, I think that is signaling to acute care providers that they have to be more collaborative with their post-acute partners across the board. And it's not just about one condition. And I think there will be a residual effect from that, right? So if I have a preferred SNF and they're doing a good job for me in CJR, they can show me that they can care for the cardiac patients as well, which most of them, if they're good, they probably can. Then you're just going to see more referrals start flowing to them, whether they're in a program or not, by nature of the relationship and by nature of the fact that the SNFs are delivering. To Gene's point, though, they're going to have to be the really good ones. And the really good ones, I think, will be winners. I agree with that. And then we will see closures.
Okay, thanks, Dave. So the next question really is around the possibility for gain sharing. We spoke about this in some of our earlier conversations about the ways in which the structure allows for both up and downside. And I'd like to speak to that for just a minute in terms of where this group sees the opportunities for either skilled nursing facilities or home health agencies to step in and claim a stake for some of that upside risk, mindful of the fact that some of these hospitals may be looking for that in a partnership. So, Julie, maybe I'll ask you, where do you see the opportunity for either skilled nursing and or home health agencies to step in and structure something that allows for a gain sharing opportunity?
Well, we actually haven't seen a lot of that in our area for a couple reasons with CJR, one of which is there's not the impetus to do it right now because there's no downside risk. Some of the acute care providers in our area have their data and feel like they have done fairly well compared to others in the area, and feel like for the first year or so they can pretty much coast, and then as the prices come down and they need to perform differently, then there might be some opportunity. I think what the big thing is for skilled nursing providers and home health providers is with this new value-based episodic payment is to really be able to understand your cost and how you deliver care, because you could enter into these gain sharing agreements, and if you don't have a good handle on that, you could really end up with some downside there, not having the process in place to shorten length of stay, manage the acuity, and manage length of stay. You could really get in trouble, but we haven't seen a lot of that around here yet.
Dave, you have some pretty strong feelings about this in terms of gain sharing opportunities. I'd like to hear your take in terms of areas in which the post-acute sector can position themselves for upside gain sharing on both of these opportunities.
Yeah, I mean, I agree with Julie, and I know in the prep call we were also, I think, sort of saying similar things. We're not seeing a ton of sharing from acute to post-acute in CJR or in BPCI at this point. CJR does make it a little bit more attractive to the acute folks by creating the opportunity to share downside. I think if I were a post-acute provider, though, I'd be wary, because at least in the early stages, because as Julie said, a lot of providers handful of CJR acute care hospitals we're running into are already doing well in the program, and so they have no incentive to share. If they're eager to share, they're probably not doing that well. So if you're a SNF and you haven't been in BPCI or don't have experience with this, go into that eyes wide open, understanding the fact that you may be taking on risk from a provider that's looking to offload downside in a pretty negative scenario. So understanding the data and the opportunity and the position is really important. I think it's going to be a while before we see a lot of that sharing, frankly, because as Julie said, there isn't a lot of downside exposure for a while yet in these programs. And so I'm not sure that that's going to create a lot of referrals or a lot of collaboration at this point. One thing I will say, though, is I do think there is opportunity for, in the right circumstances, for Model 3 SNFs who are in BPCI in CJR to partner with CJR hospitals to share the risk, because if you've already been in BPCI and you feel like you're doing well and you can handle those higher acuity patients, it does create a nice dynamic on collaborating in CJR and sharing the risk, particularly because there is that experience base there. Other than that, we're not seeing a lot of sharing.
So, Jean, I'm going to address this next question to you. So, as you're talking with either skilled nursing facilities or home health agencies, what are your top 3 things you're telling them to do now to prepare for the eventuality of this coming down the road?
Well, clearly they have to understand their numbers and where they are. And there have been a lot of numbers that are out there that have been shared or not shared, but the view of a bundled payment participant is somewhat different when you look at the numbers. Typically, the numbers, the metrics that they've had before are 30-day readmission rates. they've never had very much information on what happens to the patient afterwards, what a 90-day readmission rate is like, or having any responsibility at all for managing the patient as they leave the facility. So a couple of things, I think, in order, understanding your numbers and understanding bundled payment metrics. So that's, I think, just an important difference. I think the second one I'd add is that you really have to think about the patient in a bundled payment, in an episode. You have to think episodes. You have to think, I can't just do a good job when they're in my facility. I have to make sure that I have a good handoff, and magic handoff from a hospital. You have to make sure you're getting good information on the patient from the hospital. It's not okay to just have the hospital dump patients on you and you'll take anything they send. You really want to know about the patients. You want to get information on the patients as they come to you, and you want to take responsibility for managing the patient or making sure they go to the appropriate next set of care, and that you have good home care if you're using home care. And if you don't need home care, you're sending them home. You're efficient in that. And then I think the third thing I'd say is that, and they know this, but they need to know in a different way, which is, you have to work more closely with your referral sources, and that's an obvious, thing they need to do, but you have to do it in a different way. It's no longer about just getting referrals and in any way you can. It's really about showing the hospitals what you can do to earn that referral. Tim, I don't know if I lost you.
Sorry, Julie, this is a follow-up question for you. So we talked about this quite a bit in preparation for this call about redesigning the care model. So can you tease that out and tell a little bit more specifically how you foresee that in preparation for cardiac bundle?
Well, for any episodic payment or any value-based payment, you really need to look at redesign the way you deliver care and look at all aspects of that. And that includes things like understanding benchmarks for length of stay and setting expectations. It includes, like Jean said, really seamless transitions, having a really good care transitions program that is so you're able to seamlessly transition patients from the hospital to the skilled nursing facility, and then start that discharge planning as soon as they get there. There's so many barriers to shortening length of stay. One of them is perception. The patients perceive that they have 20 days, 40 days, 100 days. That's an example of something you really need to address on the front end. Education, as far as readmissions, we believe that you really need to educate the patient on their disease and management very quickly when they get to your skilled nursing facility, so you can have the patient and the family help to participate in keeping that patient in your building and not missing, signs and symptoms that we could react on and possibly avoid some acute care utilization. And just it's really moving away, like everybody says, from that fee-for-service world. A lot of skilled nursing facilities, ours that we work with, you kind of, I hate to say it, you kind of meander into a discharge date. The patient gets there, they want to go home on a Friday, their daughter's going to be there Saturday, and you just pick it out based on that, where what we need to do is look at the length of stay that is probably expected for that patient and the comorbidities, and try to back into that with good planning and designing the way that you deliver care. And then just really picking your downstream providers as well, and picking downstream providers that really want to collaborate and work with you. If we refer to a home health agency that just really wants all our business and is not willing to tell us that our discharge instructions aren't effective or our education isn't effective, then we can't look at improving and look towards reducing that 60 and 90-day readmission rate if we don't have people that'll collaborate and really look at how we improve care to those we serve.
So Dave, I'm going to ask you the same question. I know you've got some strong feelings about that. If you're talking with your SNF or home health client, what are you telling them now in anticipation of this arrival?
Yeah, so first fundamental question is for us, and Brian mentioned this early on, is what's happening in our market, and is this a big deal or not a big deal for us in our market? Obviously there are providers out there who are doing really well in fee-for-service, and if the market's not changing that fast, then we would never recommend that they change that fast. So, we usually start with a series of questions around what's going on in the market, who else is doing this, how quickly is the market moving toward risk, whether it's bundles or ACOs or Medicare Advantage or whatever the mechanism is, and do you see referrals changing because of that? The next set of questions is, if that is happening, what do we need to do to become, the destination of choice for the folks who are making the referrals? And, improving on all aspects around outcomes, patient-reported outcomes, quality outcomes, star ratings, understanding, as Gene said, your 90-day cost all in. So what component of that is yours, what component of that is readmissions, what component of that is ER visits. So really understanding that and understanding not just your cost, but where you compare to others in your market. So because everyone's going to be looking at that information. So good or bad, you need to know what that looks like. You need to know how you compare on a quality basis and on a patient per outcome basis, what the discharge planners think about you from a quality and performance perspective. All those things are really important. And then having a long-term strategy for how to improve and be the destination of choice. And this last one is really hard, but you can't be tied to the current reimbursement system or the legacy reimbursement system of per diem or per episode if that's not what your referral partners are evaluating you on or the mechanisms are changing. It's being willing to give up the extra days or even the episodes for LUPAs, which I know is very painful, if that's the right thing to do and will lead to a good outcome at a lower cost, and being able to willing to collaborate around that with the eye towards being the winner in 5 years and not just maximizing revenue this year.
Okay, thanks, Dave. So I'm going to turn to Brian now for our final question as we're getting near the end of this webinar. So clearly, we're now seeing the second wave of mandated bundles, and there was more than the fair share of speculation around what the episodes would be. And so, Brian, my question for you is it a foregone conclusion that we're going to see more of these? And where do you believe the next opportunities are? And then, just as important, is the model of a capitated payment model something that CMS believes is going to stick for the long term and replace some of the voluntary BPCI models?
Yeah, so there's a lot of questions in there, but generally I would say, and we talked about this at LTC 100, that these models were the first of what I think everyone or most people expected were more to come, and this is yet another reinforcement of that. So, globally I would say this is not a surprise. It wasn't a surprise to those of us who work in the industry, and we can absolutely expect more of this to come. Bundling seems to be, one of the easier to implement alternative payment models out there being tested, and I use the term easier in a relative sense. Obviously, all of these models are very difficult. They're extremely complex. You can tell just by the length of the rule itself how complex these programs are, but when you juxtapose them to certain primary care models that may be difficult to scale, or ACO program, which in its multiple iterations has undergone tweaks and things to combat its challenges. I think CMS clearly is very bullish on bundles, and particularly 90-day bundles that begin with the hospital and go downstream. So, there's several signals now with this most recent announcement and starting with CJR of where CMS is policy mentality is, at least for some of these high utilizing DRGs. So I do think we'll see more of that. The other thing I think we'll see is scaling of these programs. So I think, most people consider CJR and this latest bundle to be somewhat of a scaling of the ACE demonstration and BPCI, because these were very popular. They were the only conditions in the ACE demonstration, and they were popular conditions in BPCI. And so in many ways, this mandate is a scaling of what started as a voluntary BPCI program. So I think to your other question, clearly these mandated bundles are a way to push the market sooner into very targeted areas of risk when it has been somewhat hesitant to do that on its own, particularly, again, in the ACO program. But we even saw that with BPCI when they forced providers to move into phase 2 or exit the program, and we saw a lot of exodus within the program at those timelines. So I think you're correct that this is clearly a way to push providers into greater risk. Will there go next? It's an interesting question. I think there aren't a lot of obvious next, in my opinion, and the reason I say that is really twofold. So, the ACE demonstration is where we had the most history and the most evidence around a payment model like bundling, and they've now, with these two announcements, targeted those two key areas where we did have ACE results and ACE experience. And BPCI, we haven't received an evaluation report since really the first quarter of the program. So we're, now years into it, and the industry is anxiously awaiting the next evaluation report. I think that evaluation report will be a huge signal of where the next likely direction will be for mandatory bundles.
Okay, well, that was a thorough answer, so thank you. Brian, you referenced a couple of times that this conversation at least got started in this year at LTC 100. Lincoln Healthcare Leadership as an organization has many opportunities on the horizon, where we'll be talking about this and other areas of value-based care. A couple of that are coming up in 2017 include our Home Care 100 conference, which is February 4th to 7th in Amelia Island in Florida. Our Senior Living 100 conference, March 6th to 8th at the Ritz-Carlton Golf Resort in Naples, Florida. Our Post-Acute Link conference, which is in its second year after a very successful inaugural launch, will be taking place June 11th to the 13th at the Sheraton in Chicago. And last but not least, in the post-acute space, LTC 100, April 30th to May 3rd at the Breakers at Palm Beach, Florida. So if you're interested in continuing this conversation, there are many of opportunities that we have on the near-term horizon. I want to thank Brian, Dave, Jean, and Julie for your contributions, a very good conversation, and remind everyone that we will be sending out a link with a link to an audio file for this webinar. And thank you very much for tuning in, and we look forward to having you at a future webinar. Thanks a lot, everyone.
Thank you.
Thank you.
Thank you.